I'm really pleased to be chairing this webinar today. It's the VCCC Alliance Multidisciplinary Approaches to Tongue Cancer webinar series with the broad title of What Can We Do Better? And today is a multidisciplinary team meeting discussing 2 or 3 clinical cases. So I'd like to thank the whole team, and I'll introduce you to the participants very shortly. I'll begin first by acknowledging that we're on the lands of the Wurundjeri people, who've been custodians of this land for thousands of years, and acknowledge and pay our respects to their elders, past and present. I'm just going to move forward. So Professor David Wiesenfeld is coordinating this seminar series, and he's director of the head and neck tumour stream and lead in head and neck research and education as part of the VCCC Alliance. Okay, so the team who is participating today in our multidisciplinary team meeting is myself as the moderator, and we have team members representing various roles within the multidisciplinary team, and they are listed here. And today's MDM recording that you'll be able to listen to at in your own time is going to be part of a seminar on June the 7th, where there'll be a 10-minute presentation with the broader aim of discussing MDMs and their role in clinical and ethical decision-making for tongue cancer. Some of the questions we'll address on June the 7th will be, why have an MDM and what are their goals? What's their specific role in tongue cancer? What makes an effective MDM? And when and how are MDMs ineffective? And with reference to this recorded MDM session, we'll be looking at some ethical issues raised by the cases, and we'll also be discussing the clinical pros and cons of various decisions. So I'm very much looking forward to discussing these cases with the team. So I'm going to ask now for Tim to present this first case, and for everyone else to put on their cameras and be ready to discuss. So thank you, Tim.
So the first patient that we're going to discuss today is a young female, 40 years old, drinking about 3 glasses of wine, but being a non-smoker, who presents with a significantly advanced oral tongue primary cancer with swelling in bilateral lymph glands. Next slide.
Great, I'm a bit slow.
So the clinical and radiologic findings are of a more than 5 centimetre tumour arising from the left anterior tongue crossing the midline, and bilaterally enlarged lymph glands up to 3 centimetres on the left and just over 1 centimetre on the right, but with a clearly necrotic centre. The staging based on clinical and radiology findings is T4A, N2C, M0. The surgical plan, as discussed, was that the patient would receive a preoperative PEG for feeding, a tracheostomy tube, a wide local excision of the tumour, including 15mm margins around the macroscopic tumour, which will be a near total glossectomy, including bilateral neck dissections and ALT free flap repair, and then plan for adjuvant therapy.
Now, I think the idea is that this was actually done, the treatment was completed, and then 6 months later, this same patient presents with a supraclavicular node deeply attached. And the aim of this discussion now is to decide what would be the most appropriate next steps. Is that your understanding? And I can see that the options might be further surgery, chemotherapy, immunotherapy, or a change in goals of care. And so I'm wondering whether anyone has views about this. Is there one of these options that stands out as the best one for this patient, or maybe they've all got pros and cons? Does anyone have any comments? Does anyone have something that stands out as best in their view? So
to start with, we've got a very young patient. In general terms, when we see a 40-year-old female non-smoker, we know that the biology of the disease is likely to be aggressive based on the advanced stage of presentation. We know that the prognosis of an early recurrence, so anything within the first year is considered an early recurrence, is likely to reflect very aggressive biology of the tumour. In general terms, the MDT would take a very aggressive stance in a young, non-smoking patient. In other words, if there was any realistic chance of cure, which would traditionally have been surgery, although Luke may make a comment about whether immunotherapy has changed that approach. So generally, once you've had chemoradiotherapy, we wouldn't anticipate any further significant control with additional radiotherapy and chemotherapy. Generally in isolation, with the exception of immunotherapy, would be a palliative measure. And so if surgery were physically possible, it would be considered. Very often, the resection of a supraclavicular node is highly morbid, often with resection of vessels around the root of the neck, often with resection of functioning nerves around the brachial plexus, and with a very guarded prognosis. So surgery would be undertaken on the premise that it was the most traditional curative approach with very significant morbidity and a very guarded prognosis, especially in the absence of the possibility of additional radiotherapy for local control.
Yeah. So, yeah, what I'm hearing there is that what would make you decide to go down that surgical path in this patient? Does anyone want to, or before you answer that, does anyone else have a view about this list of possible options now, whether they think one stands out as possibly the better one, and why?
Can I jump in there, Claire?
Yep.
I just want to follow on from Tim's very insightful commentary about the fact that this is a very young woman with very bad disease with very early recurrence. Obviously, the description here doesn't say that we have necessarily a tissue diagnosis and imaging and staging so that we know the extent of the disease and have confirmed that it is a recurrence of head and neck cancer, but presumably we would say that that's the case. Having said that, breast cancer can present as supraclavicular nodes. And so in that setting, it would be important to get that diagnosis so we could entertain what appropriate chemo and immunotherapy could look like, depending on the nature of the disease. So I suppose from this point, it would be reasonable to say we've done that. And if everyone's happy that we're moving forward as though this is a recurrence of the same primary tumour that the patient had previously. Is that fair?
Yeah, I think that was the idea.
Thank you.
And yeah. Any other comments about options that stand out as?
I'll make a few comments about from the systemic therapy point of view. Firstly, I agree with what Tim said. This is a young lady, so if anything's amenable to curative treatment, that's going to be the preference, as our systemic options, particularly with immunotherapy, have really only been validated in the incurable setting. There are trials regarding neoadjuvant immunotherapy, but the phase 3 data is still ongoing. And outside of clinical trials, we don't actually have access to immunotherapy in that setting.
Mm-hmm.
The second thing to clarify is the exact timing of the recurrence, because as well as what chemotherapy was given with the previous radiation, this is really important from a platinum resistance point of view, as in terms of systemic chemo, the first line would be some sort of platinum doublet chemotherapy regimen if we were to give chemotherapy up front. But if that progression had occurred within 6 months of the chemoradiotherapy, that it's unlikely we'd expect much of a response by giving a quasi-neoadjuvant chemotherapy regimen. Progression within 6 months of chemoradiotherapy with a platinum agent also does give us access on the PBS to single agent nivolumab, which is immunotherapy. However, if it's beyond 6 months, then we don't have that access.
Is that because the 6-month window represents the optimum time?
Yeah, so the 6-month window is what we tend to use as a definition of platinum resistance. So if someone's not platinum resistant, then you could re-expose them to platinum chemotherapy. But if they've progressed within that 6 months, then the expectation is the chance of a response is small. So you move on to immunotherapy.
Yeah.
And then I guess talking about our standard of care chemotherapy approaches, it's really important to work out whether she's a trials candidate, because obviously she's ECOG 0. There wasn't a lot in her past medical history that would make me worried about contraindications to immunotherapy. But our current standard of care for recurrent and metastatic mucosal head and neck SCC is either chemo and immunotherapy or immunotherapy alone, as was shown in the Keynote 048 study. And that's not currently an option on PBS. So we usually try and get these patients who have recurrent incurable disease onto a clinical trial. But that obviously wouldn't work with a neoadjuvant, this kind of neoadjuvant approach. And then the final thing would be to add a CPS score, which is what we use as a marker of PD-L1 status to predict immunotherapy response, because that can help us work out whether we're likely to actually derive any benefit from giving this lady immunotherapy. If her score was 0, then there's really the expectation is that there's no benefit from adding immunotherapy. But then the higher and lower scores can help us work out whether we give chemo and immuno or just immuno.
So I'm hearing that you're wanting a bit more information and clarification about this patient before any sort of clear pathway emerges and any decision can be made. Is there anyone in the group who's prepared to say where they think this might go, given the information that you have? Or is it really open?
This is CN here. I probably wouldn't be brave enough to say where this would go, but as we've all been saying, this is a young lady and about to embark on potentially pretty morbid treatment. And we always are very careful, obviously, to make sure that she doesn't have metastatic disease already. And I don't know if further staging has already been mentioned, but it would be really, really important in this lady to make sure that there's nothing elsewhere in her chest or in her bones with proper staging. I do agree with Tim that retreatment with full dose radiotherapy is generally a no-go for someone like this, but in a case where she's potentially got something that's resectable and it's perhaps a node that's arisen maybe on the edge of the radiotherapy field or has only received 50 or low 50 gray, then we would potentially entertain retreating her to a lower dose, to a localized area, if there was concern following salvage surgery. So I don't think we would write her off at this point in time for further treatment, and we may well talk to our chemotherapy colleagues to see whether some chemo could be added to improve the effectiveness of radiotherapy.
Okay, so I'm interested in Sarah and Cassie and Kat's view about this patient. What are you thinking about this patient? You'll be thinking differently maybe to what it's going to be like for her afterwards. So any thoughts from you? Sarah, maybe.
Yeah, I can jump in on that one. So I guess with this lady, given the extent of her previous surgery, she's someone that we would be expecting would already be experiencing a significant oropharyngeal dysphagia, a significant difficulty with their swallowing, someone who might be maybe managing some fluids and maybe a little bit of runny pureed foods, but potentially no more than that, and maybe unlikely to progress past those consistencies. Having said that, with any of the treatment options that are potentially planned for her, I wouldn't necessarily think that any particular one of those would impact further on her dysphagia, unless, say, perhaps the surgical plan, given the location of the recurrence, would involve her recurrent laryngeal nerve to any extent. That would be the only consideration I think would need to be taken into account that could further compromise an already compromised system. But if that wasn't the case, I'd be thinking this is a lady that we would need to keep a close eye on throughout whichever treatment pathway she ends up going down, to make sure that there's no further deterioration in her swallow function that could change what is or is not safe for her to be eating and drinking. Okay, so that's really interesting that these treatments may not, she's sort of almost as bad, she's already got a really bad effect on her swallowing, so the treatments are not necessarily going to make it that much worse. Absolutely, and I think that probably stands true for her speech function as well. We'd already be thinking that this lady would have a significant impact on her communication skills from her previous surgery, but that none of the planned treatments would necessarily make that more challenging for her than it already is. Yeah. Cassie or Kat, do you have any comments?
Sorry. Go. I can jump in. So to follow on from Sarah's comments, so this lady already has a PEG in situ, which I imagine is being used for most of her nutrition. Given her ECOG 0, I would suspect that she's doing relatively well with that nutrition, but again, not sure of her current regimen and what she is managing orally. So I guess from a nutrition point of view, we would again keep a really close eye on those feeds, just to make sure that none of these treatment options do impact her nutrition, such as any nausea or vomiting or those sorts of impacts from potential treatments for these treatment pathways. But again, they can kind of be managed medically, and we can change feeds around as well to make sure that we're still getting in enough nutrition. And yeah, keep a close eye on weights and things as well, to see if we need to adjust feeds if her requirements do increase with any potential treatments. But otherwise, it would be similar to kind of what the speech has recommended, that not much of those things will change or have a huge impact on her nutrition that we wouldn't already be able to well manage, given the PEG is already there.
Yeah. Okay, so that's interesting, and it's similar to Sarah. And Kat, did you have any other final comments there about this? Any thoughts?
Mine wouldn't be so much on more of a medical side of things. I would more be looking at, like, she's a 40-year-old woman and seeing how she's coping with it all, sort of trying to get her to make her own decision of what she thinks is going to be the best thing for her, making sure she has social supports, emotional supports, potentially financial if she's unable to work. Does she have children? Who's helping her with all of these other parts of her life other than just her illness would be my biggest concern at this point.
Yeah, and which is a nice segue into my final question, which is if this patient said she'd had enough, she didn't want any more treatment, would the clinical team feel comfortable with that choice, or do you feel that the options highlighted in yellow should really be pursued?
My comment about that, Claire, would be that we would be very open to stopping on this patient, but and I think Michael and Sien and Luke would agree, the overwhelming tidal wave is usually the other way. We can see the writing on the wall at 6 months, this is not going to end well, and we sell that. But if you give them a slither to say, look, we can't see any definite distant disease, this is potentially resectable, they would jump at that.
Yeah,
Maybe I could ask Kat a follow-up question.
Yeah.
She's not going to heal well, Kat. You're a wound specialist. This is a fully radiated field in a previously dissected neck. This is going to be a long healing. How, in someone who's obviously attached their hopes to a very small chance of cure, how do you approach the wound that's not going to heal well, number one, and number two, her mental state? So she's going to come into this with holding on to a 10% chance of cure. And then it may be her last 3 months. And we have put her in hospital for a significant period with significant pain, probably a second free flap. Michael might not be unreasonable, you know, with a significant skin defect in an irradiated field. How are you going to approach those two questions, Kat, the wound and her mental state in what may be her last 3 months?
Thanks, they were great questions. Setting her up with, we have, I know here, and I'm sure every other hospital does also, we do have a very good 2 different wound services for outpatients, making sure that she would be linked in with people that are able to provide care for her on a wound side of to help with that, and linking her in even with community services that can go to her home to, you know, minimize her amount of times that she has to come to appointments, because if she's deteriorating, feeling unwell, no one wants to be coming into hospital appointments. Linking her in with community support groups, psychology here in the hospital, or a mental health care plan through the GP and the community that way, making sure that her family and support system also know that they have support groups that they can go to through the cancer council and things, and just making sure that she knows that she has the right to say yes and no to everything that goes on for her, and she's the one ultimately that is fighting this, and we do everything to support her through it, not that she feels she doesn't have to do what we want. It's ultimately up to her family what happens with her care.
Thanks, Kat. And I'm aware that we're taking a while with this patient, but it seems to me that two ethics questions arise, and one is, you know, do the benefits, potential benefits of any of these treatments outweigh the burdens associated with them, and so should clinicians even offer some of these? Should they even be available for patients to decide? Is that just too harder question for patients? But that's going to take another hour's discussion, so we might not answer them. I'll just end with those two questions, and we might go on to the next case and briefly discuss it, just more quickly perhaps than this one. But so either Tim, or I note that David is with us now. So David, would you like to do this one?
Yes, this gentleman has come to see us. He's 68 years old, lives at home, cares for his invalided wife who has dementia. He's been a smoker for 20 years. He engages in daily activities around the home, does a bit of gardening, doesn't do much more than that. He drinks occasional wine, and he's turned up with a 1.5 centimetre right ventral tongue ulcer, which when you feel it with bidigital palpation, feels like it's 5 millimetres thick. A biopsy was done, which showed the base of the tumour, and the SCC, it's a squamous cell carcinoma of the tongue, it's at least 4.1 millimetres depth of invasion. So we've got a proposal for treatment, so firstly his imaging. So he had a CT of the head, neck and chest, which showed the asymmetric abnormal soft tissue thickening overlying the right tongue. The abnormality measures about 17 millimetres in the coronal plane. There's no evidence of bony invasion. There's no enlarged cervical lymph nodes, no evidence of thoracic metastases. And an MRI demonstrated 5 millimetre thick right tongue lesion, well clear of the mandible, which staged him as T1, N0, M0. Standard proposal for treatment for this early tongue cancer: tracheostomy to airway support during the surgery, a partial glossectomy with 15 millimetre margins in 3 dimensions. The thing's already 5 millimetres thick, so the excision will be 2 centimetres in depth. An ipsilateral neck dissection on the basis of there is greater than a 20% risk of having nodal disease with a 5 millimetre thick tumour. The defect is going to end up about 4.5 to 5 centimetres in diameter, plus 2 centimetres deep. And the recommendation was that he have a radial flap repair and post-operative radiation therapy to be considered pending the pathology result. The patient refuses the treatment. He refused the tracheostomy, refused the neck dissection, refused the flap. He just wants to have a simple excision that he can get out of the hospital in 48 hours and go home and look after his wife. So the discussion is, what should we do? Do we agree to this abbreviated treatment, which we don't think is in his best interest? Or do we facilitate respite care for his wife? What can our nurse coordinator do to help? What can our social worker do to help? What can our clinical psychologist do to help? There is an increased risk of failure with this simplified treatment. He'd need close surveillance, including regular scanning, ultrasounds of the neck, the speech and swallowing issues without reconstruction. And we've hit an impasse. The patient's made a decision.
Thanks, David. So I'm interested in your initial responses to this one. This one is a bit more clearly in the ethics space. It seems to have a should question attached to it. Should you just accept this patient's decision as it is? Would you be prepared to do that, or would you be thinking more needs to be done?
I'd maybe start off, Claire, and say that I'd say this is a relatively common scenario where a patient is expressing a clear goal of care, which is slightly different to our first goal. So our first goal is cure the cancer, which would include the neck dissection, and we have randomised studies that show that that neck dissection in this situation will improve his survival, but by a small order of magnitude. Our second goal would be to improve his functional outcomes. Sarah will have specific comments, but in general terms, we find that the functional outcome is better with a flap, with a sizable tongue defect. But his goal of care is short hospital stay, early return to care. And so I think it's very important that in all clinical discussions that we consider the patient's goal of care. The only thing I would say slightly on the other side, Claire, is it's very hard for clinicians to give advice, particularly in a life and death situation, and then the patients to entirely be selective about what part of that advice they will accept. It's in this case, I think his changed goal of care is entirely reasonable. The order of magnitude of reduction of cure is small. You know, maybe he's got a 5% higher risk of dying from this cancer total, but with careful surveillance that can be minimised. I think his request is entirely reasonable, but it is a spectrum. Patients cannot tell us what they think is the best care. We can advise the best care, and they may not accept it all, but we're not going to turn the seesaw and have them tell us what best care is. And there has to be a compromise.
Yeah, thanks for that, Tim. And I think, so is anyone thinking that you actually are feeling like you should be trying to persuade this person to have, this patient to have the bigger surgery? Do you think would you be thinking that is important, or are you all thinking along the same lines as Tim, that ultimately there's not such a big difference?
I'd like to jump in there, Claire, if I may, because often the degree of reconstruction that we do does have a significant bearing on how long a patient might be in hospital and how much they're recovering, or how much is added to their recovery, in addition to any post-operative radiotherapy. A free radial forearm flap is a great suggestion here because it's very soft, pliable tissue. It's a very robust flap, but it is a free flap. And so that is going to add another, donor site that's outside the field, which may affect his mobility, may make it more difficult for him, particularly should he get a wound dehiscence or a skin graft, loss from the donor site, to be getting back to the capacity to care for his wife. And that may direct us to, choose alternative reconstructive options, or at least discuss those with him. And that would be things like a submental island flap, which is a local flap. It's quite capable of doing this, and it's particularly useful in patients who have, ventral floor of mouth or ventral tongue defects of this sort of size. It's probably getting to the limits of it, but he is 68, so he's very likely to have, a significant amount of tissue in the submental area. And secondarily, with postoperative radiotherapy, the issue with hair growing inside the mouth is usually abrogated. One of the main problems I've had historically are patients who are definitely going to get radiotherapy. We give them this flap, and then the good news is they don't need radiotherapy anymore. And now we've got the issue with hair inside their mouth that they have to manage.
Yeah, okay, right.
And it'd be great to get the opinions of expert speech therapists and nutritionists about things like skin grafting, with its risk of contracture, and or just a resection with mucosalization, because they do lead to less good outcomes from a functional perspective. But if I could get them to talk to that, maybe it might be a good opportunity.
Yep.
Yeah, absolutely. I can jump in there. So I think particularly if we talk about an excision alone in the first instance, so an excision, particularly if it will involve this patient's tongue tip, we would definitely be expecting to see poorer speech outcomes than if a reconstruction was to occur. So this gentleman would be losing part of one of his main articulators and not having it replaced with something that's able to facilitate the same articulatory contacts for him to make clear speech. I guess the other risk without a reconstruction is often the lack of an intraoral flap with the bulk that it provides gives a greater likelihood of saliva pooling in the oral cavity, and that then impacting further on the clarity of speech. From a swallowing perspective, I think, again, if we talk about an excision without a reconstruction, we'd expect a greater oral stage dysphagia, again, because of that lack of intraoral flap bulk, making the transfer of food and drink more effortful from the oral cavity, and potentially needing a greater reliance on compensatory strategies to be able to facilitate and make oral intake as easy as possible for this gentleman. So we do think that generally functional outcomes for speech and swallowing are improved with reconstruction, and particularly reconstruction with something that might be a small, very pliable flap like a radial forearm that was initially proposed. My comments about the skin graft or perhaps a local flap would be the potential tethering and restrictions to tongue mobility that could come with those options that would potentially be greater than with a free flap, but would provide that additional, I guess, a little bit of extra bulk than an excision alone. So I do think it's an in-between, potentially another option that could be discussed with the patient, that could be something that might help to facilitate both his goals and the goals of best functional outcomes for the patient as well. I think this is someone that just needs to be informed of all of the potential options and what those could mean functionally for him, so that he really can make the decision that's right for him. And also important for him to know what we can provide from a facilitation of care or social supports that we could help to get him through this treatment and the best treatment for him.
Yeah, so that's interesting. So there's actually, it's not just a matter of a simple surgery versus a more complex surgery. There's issues to think about even with the smaller approach, the smaller surgery. Anyone got any other comments about this that they think is important to be considering?
I was going to say I would just talk to him about whether or not his wife, as she has dementia, does she have a My Aged Care package already set up? Does she have the ability to go into respite? It may be that she's been and had a bad experience. If there's children involved, if they can help, getting the social worker involved, making sure if his wife is his biggest concern, trying to help find a way that he would feel comfortable, even for a short stay in hospital, that his wife was going to be adequately cared for, which if we can find something that works for him, he may then be happy to have the more extensive surgery if he felt that she was going to get the right care that she needed whilst he was in hospital.
Yeah. So I suppose the bottom line is, do you think that the more extensive surgery is a better option, if you leave aside his home situation, is a better option for curing? And I'm not hearing that it's hugely better than the simplified one, or are you able to say that if he
I would
was
estimate his cure to be of the order of 85% with best treatment, and I think his cure would be slightly below that with just observation of the neck. So let's say 80% if we had to throw him a number at 5 years. As Kat says, it may be a case of trying to bring in some supports for his wife. He may feel that he's the only person who can look after her, which may not be the case, especially in a short-term setting. I think it would also potentially be helpful to get some degree of assessment of the wife. We may be able to do that at the MDT. It's none of our areas of expertise, but at least to get a sense, is she long for the world? Is she managing reasonably well at home? Should she maybe even be at a stage where she's thinking about a higher level of support?
Yeah, and I think all of those. I had another question I was thinking about. Does it matter what if he doesn't appear to understand the implications of either option? That he's sort of a bit blinded by, other tasks, or he's not in a good mental state. When does that constitute a lack of capacity? But I think you've started to answer that you would be investigating his understanding and his home situation pretty thoroughly before taking on face value that refusal. So there'd be some advocacy involved here and further probing.
I was also going to add, from a nutritional point of view, I wouldn't anticipate too many issues given that T1 nutritionally, if he was to have the further surgery, then potentially might require an NG for a short period of time post and then progress on to food. However, if he has the more simplified treatment and that does impact his swallow, he might need to be more reliant on nutritional supplements. And as Sarah said, there might also be that risk of dysphagia. So also, managing that and making sure that he's safely consuming foods, and kind of what that means in terms of potential weight loss and loss of muscle and function, and being able to look after his wife as well from a nutrition point of view if his swallow does become impacted, or he's relying on texture modified, which can impact quality of life but also can be difficult to get enough nutrition in as well. And also potentially increased appointments with dietitian and speech and close surveillance monitoring and those sorts of things, and potentially if there is any dysphagia, whether that's causing any chest infections that could cause hospital admissions in the future and those sorts of things. So making sure that he understands potentially the higher burden at a later date, but again thinking about his current social situation, and as Tim alluded to, what the wife's current situation is, whether he thinks this is more of a short-term goal to look after her in the here and now, or whether we do expect that we want him to be functioning really well for the next 10 years for his wife, and those sorts of considerations as well.
So it's the idea that it's a choice between an extensive surgery and a simple one is a serious simplification of the issues. There are all sorts of short and long-term considerations by the sounds of things.
Claire, I would, sorry, it's CN here. I would just add that given what we know about this gentleman's case, we would be mindful of the fact that even if he does have indications for radiotherapy, he's likely to be also someone who would say he doesn't want adjuvant treatment, or it would be actually quite difficult to get him through it. Keeping him in good shape to look after his wife.
Okay. So I think we won't go on to case 3. We might draw this meeting to a close. I'm going to stop sharing the slides and thank everyone